Yes, go ahead. Is there a risk to the donor?
Yeah, so there's risk in every surgical procedure that we do, but the important thing to understand is that once you've been medically cleared to be a donor, there's no decreased life expectancy. There's no significantly increased risk of kidney failure. People live normal, healthy lives with one kidney, and I think that's that's the biggest take-home message that we tell patients. Obviously, there can be surgical complications, but that rate is extremely low, so it's very safe.
Okay.
Oh, yeah, what's the first question? I'm sorry. Oh, yeah, so so people are living longer, healthier lives. So both donors and recipients, we do not have an age cutoff. We look at everyone, individually. And so I think the oldest donor that we've done at my current institution was 79 or 80. Yeah. That's even older. I've done 5 patients, 84 recipient, but the donor was about 79, 80.
The recipient, he's done up to 84, he said, 84 years old to receive. But to
Yeah.
give, you have to be a little bit younger. But he's done 79 before.
Yeah. Gotcha. Hard to say, but it's obviously, yeah, you need to make sure. Yeah.
That's a nephrology question. Dr. Mohiti, you want to answer that question?
I think seeing a kid, even your primary care clinician doing a simple blood and urine test to see what your kidney function is a good idea. There are a lot of people who were impacted by COVID in terms of kidney function, so we recommend that to everybody. It's important to screen and all of that. Some studies have, yes, shown some long-term effects for some individuals, and some individuals had recovery depending on underlying factors.
Okay. You have a question over there? Mm-hmm. Let me see the chart.
Hi, good afternoon. I've learned a lot today. Thank you so much, all of you. I wanted to know, Mr. Rang, what are you doing? What is being done for the providers to actually realize that some patients that do get acute kidney failure can end up with chronic kidney failure in the future, and to help prevent? This is personal for me. My mom had abdominal surgery last year for cancer and went into acute renal failure within 1 week. She resolved, but what happened was they never recommended her to follow nephrology, and now a couple of months ago we learned that she has stage 3 kidney disease, kidney failure. But her PCP was good, as you said. They did give her a SGT1, I think, TL2 inhibitor, and it actually started to slow down the progression of her kidney disease. So my thing about it is, just like the providers they didn't do anything, they just left her alone because it resolved within 7 days. What is being done to actually make sure that the providers are aware that this is an issue, and when you have a patient that goes into acute kidney failure because of surgery, to actually have them follow a nephrologist so that they don't go into acute kidney failure? That was my first question. My second question is the gene that you talk about. Is it a regular blood test? How do you go about getting it? How do you educate the public to ask their providers to have the test done? And is it covered by your insurance? Is it a regular, blood test done? And do the insurance companies cover this? Because a lot of what I've realized is being a nurse for many years and being a nephrology nurse now is that a lot of our patients, education, they don't know the rights. They don't know what to ask for. Many of them don't know that actually that the
question
doctor
has to be brief.
I'm sorry. That they exactly what is being done actually in both scenarios to make the public and do the insurance cover.
Yes, thank you
That's
for
my
your
two
question. So in brief, for your question one, I would say that there's a lot of development in terms of improving the care for AKI survivors. There's a lot of post-AKI clinic that are actually being studied, NIH funded, and we're trying to prove that patients who are AKI survivors, after having survived episode of AKI in a hospital and getting out to the primary care and out in the outside of hospital, if they're being seen by a comprehensive care, by a nephrologist or by a nurse or by a pharmacist, the likelihood of them getting revert back to baseline creatinine is higher than having no follow-up. So there's a lot of literature surrounding that, and it's one of the initiatives by Kidney Health, KHI, that is trying to increase awareness of AKI survivors. And I think Dr. Marches will be able to answer this more in terms of follow-up care and how we can prevent the progression of CKD among Black patients. To answer your second question about NephroCheck. So NephroCheck is not approved to be used in an outpatient setting, as currently can only be used in an inpatient care. And inside a hospital, there is, regardless of your insurance, if the treatment team decided that a patient will be benefited from getting a NephroCheck test kit, that shouldn't be a burden on the patient side. It will be a burden on the hospital side.
Right.
And the cost associated with NephroCheck is actually currently kind of high. It's about $100-something per test kit. But I think it's because we don't use it often, so the cost stays high. If the demand is higher, the likelihood of getting this cost could be lower in the future. And also because we also use this kit among patients who I think we can be advocating for, patients who are at a higher risk. So if we have a higher demand, I believe in the future we may be able to use this kit at a cheaper price, because the cost of someone who has ESRD.
Brief answers.
Okay, all right. Thank you.
Okay, Dr. Moitish, you want to answer whether the CKD screening is paid for? Who is paying for it, and what is it? Is it a urine test, blood test? What is it?
Yeah, sure. So I appreciate the question about APOL1, and I think there's a lot of different groups that are offering APOL1 testing. I can speak to where I practice at the Veterans Administration. It is free. I use my clinical judgment based on their family history and risk to test. There are some organizations who are offering free testing, however. So, I think it's something to have a conversation with your clinician about, especially based on family history.
Okay, we have a question over there. Brief question. Mm-hmm.
Good afternoon, everyone, and thank you for
It's
the
not a lecture, it's a
presentation.
question. Okay, go ahead.
Yeah. My question is about the transplantation. I'm asking in a family where there is a genetic kidney problem, like polycystic kidney disease, is it a good idea to get a donor in the same family, like between close family or sibling, for a person who need transplantation, or in other words, this transplantation may impact or may affect the survival after the procedure? Thank you.
I'll be brief. So what we do typically is just ensure that the potential donor does not have polycystic kidney disease, because it's not full inheritance. So just because one family member has it doesn't mean, let's say a sibling, doesn't mean that the other one will. So what we do is just ensure that donor doesn't have polycystic, and then it's perfectly fine. The other answer is that we want a living donor that's healthy, whether it's a family member, a friend, a stranger. So as long as they're clear, then it'll be fine.
Okay, Dr. Watson, I have a quick question for you. You had mentioned that the ATAP funding was cut or something like that. Are you still able to continue the study?
So we actually were part of the same consortium. So it was roughly 5 projects, I think, that were all defunded. We got defunded right when we were about to go live with enrollment. So we're on pause until we can get the funding to proceed. Because I would like to do it in a research capacity. Worst case, we could still do the program without, with less fidelity. But I think that impact would be minimized. So my goal is to get the funding for the research coordinator, et cetera, so to still do it the exact planned way.
Okay, very good. Thank you. Yes, there's a question in the chat. Go ahead.
Hi, there's a question for Dr. Rung. As it pertains to hospital-acquired AKI, would a medication reconciliation be a therapeutic intervention that could help mitigate hospital-required AKI? If so, is medication reconciliation practiced at your institution, and is it a service provided by pharmacists?
Thank you. So as a pharmacist, we always emphasize greatly on reconciling the medication that the patient is using prior to coming, during the stay, and then when at discharge. There's a lot of quality improvement project that showed even AKI survivors, they are still discharged with 1 or 2 at least nephrotoxic agents. So at our hospital, we have an initiative to either reduce nephrotoxin burden on admission during AKI, and if it's not modifiable, we try to come up with a interchange that we can use that is less nephrotoxic. And at discharge, we have an initiative to also reconcile all the medication lists before we send a patient home to minimize the progression to CKD in the future.
Okay. I would ask Dr. Mohitej a question. You had mentioned that you had a Senate hearing following the withdrawal of those funds with your community advisory board. What was the reaction of the Senate Health Committee members?
Thank you. We met with staffers for a few different representatives, including AOC, who represents the Bronx district. It was, I think, incredibly important for them to hear from patient voices. And our stakeholder board includes people from New York City, but also around the country, just to hear how much hope has been kind of almost stolen from them for new discoveries, and to hear about how much this is going to erode trust and continued, kind of clinical engagement and clinical trials. I think it was very powerful for all of us to be together in that space. What will come next, I think, is the biggest question. I know they were trying to hear from as many defunded investigators, and it was particularly important for them to hear the patient voice. So I encourage everybody who is in this situation to ask patients and community organizations to speak truth to what is really happening. We need more of our representatives to hear the profound harm that is being done.
Okay. All right, it's exactly 1 o'clock. So I want to thank the speakers for a wonderful job done, and thank you for coming for the conference.